Now we invite Dr. Manish Parikh for complex case presentation.
Okay, thank you, Chairman. And it's really wonderful to be here. I have about 5 or 10 minutes. I'm just going to go through a few cases, the good, the bad, and the ugly. So this first case, this is a 75-year-old patient of mine, very similar to many of yours, hypertensive, tobacco smoker, hyperlipidemic. But in addition, he had severe peripheral vascular and carotid disease, who presents with classic symptoms and a positive stress test. You know, he's got bad kidneys, he's a COPDer, he's had a AAA done. His echo suggests mild LV dysfunction, he's got terrible triple vessel disease. His syntax score is 32. So we did the diagnostic procedure, took him off the table. We then discussed coronary bypass versus multivessel left main stenting. Again, remember his creatinine is 2. He's got bilateral carotid disease. He's got peripheral disease. He's got bad conduits, and I don't know what surgeon would want to take him, but we actually consulted with several surgeons, all of whom gave him a very bad prognosis. And then with collaboration and discussion with this heart team approach, as Ajay said, it ended up coming back to me because no one wanted to really take care of him. So here's his angiogram and procedure. This is his AAA repair. So you can see what kind of access he's going to have or not have. This is his coronary anatomy. He's got a high-grade distal left main involving the proximal LAD, which you'll see, and a mid-LAD. Here's an LAO caudal. The circumflex is angulated significantly. There's a tight bifurcation distally. This is the AP cranial, RAO cranial view. You see that the LAD diagonal bifurcation is also significant. So these are great conduits. Okay, this is a slam dunk for surgeons, but he's got bad carotid disease, bad endovascular disease, bad kidneys, and bad lungs. So he falls into a very high risk group. So I ended up doing this procedure. This was my strategy. I didn't really have any hemodynamic support to give him because of access issues, but I did get a contralateral access. We used an 8 French guide. We did a right heart before we started because his renal insufficiency, I wanted to optimize his hemodynamics. In this case, I used bivalirudin. He was Plavix and aspirin loaded. I actually decided that I was going to ultrasound the LAD and the diag, the left main LAD and left main circ, so that I could then decide up front what strategy I was going to use, 1 stent versus 2 stent. So here's what we did. We wired both. We IVUSed after pre-dilating the left main. There's tight disease in the left main osteo-LAD, but not significant disease in the origin of the circ. So then this tells us that a single stent strategy will suffice. We subsequently then wired the LAD, the diagonal, the circumflex, and stented it. So this is the PCI first of the mid-LAD through the left main, and he was stable during this. Again, all this is done fairly quickly. This is a 3012 Resolute. I always like to jail my wires. I don't want to lose side branch access, so we did that here. And the origin of the diagonal was a little bit compromised, so I rewired it and ended up with kissing balloons there. Again, just pre-dilating the left main allowed me enough purchase to get product down. The guide, as you notice, is outside the ostium, so I'm actually not up against this tight left main, and I'm watching my hemodynamics. Again, everything is ready to go. This is a 4.0 Resolute in the distal left main. Okay, and you could probably imagine that this is not well opposed. The left main had a 4.75 millimeter diameter. How did I know that? Because I ultrasounded it to start. Post-dilated with a 4.5 to high pressures. 1 stent strategy. You see the circumflex looks very nice. The wire is trapped. I then rewired the circumflex. I IVUSed the left main LAD circumflex after post-dilating. And this is my final result of the LAD diagonal. And I can tell you that the patient, we used a total of 90 cc's of contrast. Patient didn't wince, and this whole procedure took about 50 minutes from start to finish. Again, this was planning, keeping it simple, and understanding what you really need to do when you get into a procedure like this. So this is the final result of the LAD diagonal. So really, the take-home message for this first quick case is that the heart team approach at many times can work. Depends on who your surgeons are and if you're going to collaborate. Keeping it simple, I think IVUS is underutilized, and in complex cases like this, if you do not have IVUS, your procedure will not go as well as planned. And more importantly, the safety and efficacy for the patient is going to be compromised. I think you need to be compulsive with technique, and use of drug-eluting stents is very, very important as long as the patient can continue their dual antiplatelet therapy. And I think the current and future techniques, technologies have and will continue to permit complex cases to be achieved in a very safe manner. Very quickly, I'll do one last case in the last few minutes. This is a 69-year-old male with multiple risk factors and dyspnea. He's on those medications. He has a very positive stress test with mild anterolateral dysfunction. And this is his coronary angiogram, high-grade proximal circ, some distal left main disease, high-grade mid-LAD at the bifurcation of the diagonal. And this looks like it may be thrombus or calcium. Well, he's not having an acute coronary syndrome. He's got class 3 symptoms. So this is calcium. You see the amount of white stuff on your angiogram. And when you see an angiogram like this is all calcium. So you should be thinking of something up front. Here's your LAO caudal view. Gives you a good sense of the disease. You don't have much purchase in the left main. His right coronary is loaded with calcium, but is relatively non-obstructive. And here's ventriculogram. The anterolateral wall is clearly hung up because you have TIMI2 flow, but presumably viable. So, this man has multiple risk factors as well, including bad lungs. Discussion with him, his syntax score is 18. He decided he wanted percutaneous coronary intervention. And I think that if you do the right things, you could get through this case with 2 to 3 stents and get him through it. So what we decided to do, this is a 7 French EBU guide. We ended up using a roto-wire and a 1.5 rotational atherectomy burr. This case cannot be accomplished well without rotational atherectomy. You could try to put in as many balloons and expand them as high as you want, but you will not get any optimal result. So this is after 1 burr. You see that you've at least debulked a little bit. The origin of the diagonal clearly looks very hazy. We've then pre-dilated with a non-compliant balloon. Subsequently, we pre-dilated the diagonal as well with kissing balloons to prepare this lesion. These are 2 BMW wires. And what I did was a T-stent or tapped stent technique using Zion stents in the diagonal and the LAD sequentially, 2.5-15 and a 3.0-18. Post-dilated it with non-compliant balloons and ultrasounded it. And I have to tell you, the patient did very, very well. I'll show you the final result. This is the final result. He ultimately came back for the circumflex, which was also done with rotational atherectomy and 1 drug-eluting stent. I was able to do this with significant contrast in 1 sitting, a little bit more radiation than I wanted. But this patient has been followed by me longitudinally. He's now out 1 year with 0 symptoms and doing very, very well. So I would say to you that keeping it simple is correct, but knowing your techniques, understanding how to do high-risk PCI procedures, and then using your colleagues around you, your surgeons and others, to help you make decisions is really the best way to go with these complex cases. Thank you.
Thank you, Manish. Very compelling and interesting cases.